Hi, Frank Kuwamura from MD Spine Care. Today we're going to be talking about a common problem I see in my clinic, which is, doctor, I have leg pain. I have pain that goes down my leg. I have weakness, tingling, numbness. Where is it coming from? This is an area where we see different types of problems. And people say, doctor, have a pinched nerve? Well, yeah, sometimes you do. Or could this be a blood vessel problem? Could this be that I'm getting cramps or tingling, numbness or weakness in my legs because I have a vascular problem or blood vessel problem? So today we're going to be talking about claudication, and that's really the symptoms. Claudication is when a patient exerts activity such as walking, and they start to experience these symptoms which are in their legs. It could be pain, tingling, numbness, or weakness. And so we're going to attack this problem from both ways. Do I have a pinched nerve, or is it a blood vessel problem? And so today we have an expert here in our communities, Dr. Jeffrey Martinez. I've known Dr. Martinez now for over 15 years. I'm a personal friend over the years, and he's someone I rely on to help me decipher this very complex problem. When the patient comes to see me, is it a pinched nerve problem, or is it a vascular problem? Is it a blood flow problem? And so a little bit about Dr. Martinez, and we're going to get him on set just in a moment. I've known him for over 15 years. He is a colleague and a friend, and I know that he has exceptional training. We're going to go some of his training of how he's trained and how did he become a vascular surgeon, and a little bit about his day and a little bit how he evaluates these patients. Later in the show, we're going to have some call-ins. I know that we've opened the lines, and you all are going to have a chance to call in and ask us questions. But without further ado, let me welcome Dr. Jeffrey Martinez.
That's right.
Hey, nice to see you, Jeff. How are you doing?
Good.
Thank you. So how was your day today?
It was good.
Working hard?
Yeah, a little busy. Not too bad. Not too bad.
Absolutely. So again, we've known each other for a very long time. Is it okay if I call you Jeff?
Sure.
Okay.
Absolutely.
Okay, Dr. Martinez, right? Tell me a little bit about your background. Where were you born?
So I was born here in San Antonio. So
Same as I.
family, we're natives, but
Yep.
I grew up outside of Dallas in a little town called Garland. Not so little anymore, but that's where I grew up.
Gotcha. And what got you interested in vascular? Because you're a vascular surgeon, right?
Right.
And first of all, tell me a couple things. What's a vascular surgeon, and what attracted you to this field?
Yeah, so vascular surgeons have had sort of this complex of who are we, what do we do? Most people think that vascular surgeons treat varicose veins, and that is some of what we treat. But
What's a varicose vein?
varicose veins are just enlarged veins in the legs. They tend to cause pain and hurt, and most people see them and can diagnose them themselves.
So those are veins that you'll see down in the legs?
They are. They can be, yes.
Now, my mom had those, and they were painful.
That's right, and they can be. So, but that's one part of what we treat, and the bigger part of what we treat really is arterial disease, and focus on that.
Tonight's topic is going to be really talking about patients that we share that have leg pain or tingling and numbness. So for our audience, let's go through some basics about the differences between an artery and a vein.
Sure. So we have really two sides of the circulatory system. We have the arterial side, and that's where the blood vessels start at the heart, and the heart pumps the blood throughout. Once the blood gets to where it's going to go, then it's returned back to the heart through the venous side. Now there's some smaller blood vessels in between where all the oxygen diffusion and nutrient diffusion and take up from the muscles and tissues occurs, but it's a circuit, and you have the arterial side and the venous side.
So the blood pumps the heart away, right, and it goes through the arteries and then comes back to the veins.
Correct.
Gotcha.
Correct.
Okay, gotcha. Okay, let's take a typical patient I'll see in my clinic. Well, first of all, before we do that, where did you do your training?
So I did my medical school and general surgery training here in San Antonio, and then I did my vascular surgery training at the University of Tennessee in Memphis. I did a little mini endo fellowship involving minimally invasive procedures.
So was that the time period in Tennessee when Peyton Manning was there?
No. I'm
Okay,
afraid,
all right. Just ask.
It was before then, so...
So you're older than Peyton Manning?
I think think I might be.
Okay, all right. I'm older than Peyton Manning.
Yeah.
Okay.
But, and so I spent an extra 6 months there learning some different techniques.
And you did a fellowship, right?
I did.
What's a fellowship?
A fellowship is training after your initial training after medical school. So I did general surgery, which is 5 years, 2 years of vascular surgery training, and then another 6 months.
And how long have you been here in San Antonio?
So I've been here since 2001. I spent some time in the Navy, as did you.
As you, right. We're both Navy guys.
That's right. And so after the Navy, I came back to San Antonio, and I've been here since.
Gotcha. Okay. So your focus is taking care of patients that have problems with their arteries and veins.
Correct.
Okay.
And I've really limited my practice now to the problems particularly associated with the legs, because we have such a big problem with arterial disease in the legs in our community.
What's the name of your group?
It's called Espada Vascular.
What does Espada mean?
Espada, the translation is sword, but it's actually named after one of the missions here in San Antonio.
Okay. All right. And so if someone wants to get in touch with you, how would they get in touch with you?
They can go to my website, www.espadasa.com,
Gotcha.
or they can give us a call.
Okay, perfect. So the topic that we're going to talk about is the difference in, so we see a patient that has, they'll come and see me. Hey, Dr. K, it happened today in clinic. A patient came to me and said, hey, and let me just tell you about this patient. So a patient comes to me, he's about 65 years old, and he says, I was a really active guy, and I played sports in high school, and I did this and that. And he works actually as in the construction field. And he came to me and says, Dr. K, my back is hurting a lot, and I'm having problems walking. And I said, well, what's happening when you walk? He says, well, I start feeling some crampiness in my back. I'm getting some crampiness in my legs, but if I walk further and further, it starts to go numb. And so I'd like to dissect that story. And that story is not uncommon for patients I see, or maybe you see that same story, right?
I'm glad we're talking about this, because this is a patient that I see too, and the story is very similar with a little variation here and there maybe. But,
okay, 64.
Okay.
No, and so
it's a common thing.
It's very common. We see it. I see it every day in my clinic, and you probably see a very similar story in your clinic.
So from the vascular side, we have what's called intermittent claudication. And
what does that mean?
Intermittent claudication is where the blood supply to the muscle isn't enough during exercise. So you can imagine that you have this pipe going to your muscles, and you've got a clog in that pipe.
Like the artery.
In the artery.
Gotcha, okay.
And so as you're walking, those muscles need more blood flow because they're exercising and they need that nutrition to keep going. When they don't get it, they begin to hurt. And so you get this leg pain when you're walking. And the classic pattern of that is, Doc, I can walk 30 feet and my legs start to hurt. My thigh, maybe my hip, my buttock, my calf. And after 50 feet, I have to stop and I have to rest. Mm-hmm. And after I rest for a little bit, I can move again, and I can walk the same distance or pretty close to it. If I carry something or have to go uphill, it's less. But it always gets better, and it's always really reproducible.
So why would the rest make the symptoms better?
Well, now your muscles are resting. They're not requiring the amount of blood flow anymore, so the muscles begin to, you don't have that buildup of the lactic acid and all, and things get better. But, there about 5% of men over the age of 70 have vascular disease. And so vascular disease is common as we age, and there's other risk factors like diabetes and smoking, high blood pressure, coronary artery disease, renal failure. All those things can increase your risk for it. But only about a third of the patients actually present with those classic symptoms. So when you're talking about these other symptoms, these are ones that now you really have to put your doctor's cap on and start parsing through those things to say, okay, is this a blood vessel problem or is it a nerve problem?
So and I'll attack the same patient. He's in my clinic. He's not in your clinic yet. So I want to tell you about how I would do things. I want to know how you do things. So the patient's in your clinic and tells you that story. What's next? How do you determine, break me step by step, if I'm the patient that comes sees you, and I do this, and what would it be the next thing you do? Would it be a history? Would it be, what would you do?
Most of it's history generated.
Sure.
So I'm really trying to get that, is it reproducible? Because most often the vascular pain is going to be pretty reproducible. And so I'll ask them several different scenarios just to see how they may respond, like walking up a hill, carrying objects.
Sure.
Maybe if they're shopping, are they having to use a cart? Are they leaning on the cart? So there's some things where you can get a little idea.
The cart. Oh, we're going to talk about the cart. The cart. It's called the shopping cart sign. We're going to get to that, so just stay tuned. We're going to talk about that.
And like I said, only
is it H-E-B cart or Walmart cart?
Either one.
Okay, all right, we're going to talk about that.
But so if I can get a little better understanding of when the pain comes on, what relieves the pain, that can direct me a little more.
So you're getting the history about what causes the problems. Hey, is it all the time? How about night pain? Could it happen at night?
So you can get pain from the circulation at nighttime. That's usually a much more advanced process. And so generally you would have symptoms before then. But yes, you can. But when we're talking about leg pain, when it's the person walking around, that's usually not going to be that person.
Okay.
One of the main questions I will ask, especially when I'm just not quite sure what is this? Is this nerve or artery? I'll ask them if they have the same pain if they stand for a while. What about when you wash dishes or you're at church and you're standing? Can you do those things? And standing should not affect the arterial system at all. The muscles are still at rest.
Right.
So if they start complaining that standing seems to bring on the pain, then I start digging through my phone for your phone number.
Oh, it's a 911 call. I got that. Okay, let's go back to you. So you've taken your history, and let's review. So there's a couple of risk factors, right? You said diabetes, blood pressure issues, smoking. What else?
High blood pressure, coronary artery disease, renal failure,
Gotcha.
High cholesterol. We will say that most patients do not progress very significantly over time unless they have diabetes or they're smokers.
Gotcha.
Those are the two biggest risk factors.
As we know, it's smoking and diabetes. Those are huge factors for just general health, and this is just another example how those two things can badly affect our system. And we've talked in the past about diabetes and high blood pressure, but back to this problem. Is there a family history? Is there a family history of
Can
problem?
be. It does seem to run in the family to some degree. That's not as big of a risk factor, but that usually all goes together. They have a family history of diabetes, high blood pressure, heart problems too. So
Gotcha. So we'll start the same. So I'd like to bring this. So a patient comes to me. I ask the same question. So we haven't then solved the problem yet.
Nope.
We still. So I will ask the same problems. Is there a history of diabetes? Is there a history of high blood pressure? Is there a problem with coronary artery disease? Is there and how does it affect you? Does it when you're walking, when you're standing? Now you ask some really good questions on my side, like standing and things that aren't active. So in contrast, I would say. I would think that for me, my problem is not a problem with the blood flow, but my problem are pinched nerves. Right? And so patients that I see that typically present with those things, they'll tell me, you know what, yes, I have the problems when I'm walking. Yes, those things. But rest doesn't usually make it better. Right? It's not the rest that makes it better. It's more body positioning. And hence the shopping cart, right? We talked about shopping cart. So that's a classic thing that I teach our students. It's called the shopping cart sign. And what we're dealing with is that as our body moves, our spine moves back and forth. I ask a question. Now, if you and I went to H-E-B and we had a long list of things to shop for, and I got my honey-do list that I'm going to do, right? And so I start my day and I start walking. Could I complete my walk and complete my task without a shopping cart? And many of my patients will say, no, I just can't. My list is too long and my legs are, and all these things are happening. Then I ask the same question, if you have a shopping cart, could you complete your task? And they go, I never thought about it, but the answer is yes. And what they're doing is really flexing their spine just a little bit forward. And see, just imagine holding on a shopping cart like this. And that simple action opens up the space in the spinal canal and unpinches nerves. So my patient will say, yeah, that improves me. What will your patient say?
Some will say yes because
you're making it confusing here.
I know, but it's because they can move at a slower pace.
Oh, okay. So it's not the position.
Not the position, but it's
the people that can't get through the aisles fast enough. So that, gotcha. Yeah. Okay. All right.
What about squatting? That was one thing that we learned, was that squatting is more of a sign that it's some spinal stenosis or the pinched nerves.
It is. It's true, absolutely true. I don't know how I can squat anymore. I'm getting a little older here. I'm older than Peyton Manning, remember? But yeah, my patients that can squat, that's one of the things I ask them. And that position certainly causes more pressure on the nerves. And my patients will tell me, yeah. And it's an indirect question I get. It's really more professional. Like the patients will tell me, hey, I'm a carpenter. Hey, I'm doing this. Or hey, I have this, do a job. And this is the position that really kind of pisses me off. Mm-hmm. And they're reproducing that kind of position. And they're coming to say those are one of the things that trigger it get worse. Okay, so what we've done, we've seen the patient. We've taken the history. We got some risk factors going on. What do I do next in your clinic?
So next is we'll do a physical examination.
Oh, good. Okay.
So
you're not one of those doctors just look and look at the study
we get our share of tests too. But,
all right.
But we start with a physical exam.
Do you think that the physical exam is a very important part of evaluating a patient?
I think it is very important, but you can also be fooled by the physical exam as well.
Sure.
So I don't think there's any one fact in their history or particular part of the physical exam or test that can make the diagnosis for you. You've got to take a piece from all that and put that whole thing together.
Absolutely.
And then come out with what you think is causing the problem.
Yeah, I think that's a great topic. People think that it's like 1 + 1 is 2. And as you know, we're all human, we're all individuals, and it's not. It's taking a piece from the history, taking a piece from this, and taking a piece with this, and taking with this. And then I talk to patients, and I'll do what's called differential diagnosis, which is a fancy medical term. Basically, we start thinking of like all the things that it can be, and then we all kind of put all these things in years of experience and knowledge and base and your wall training. Then we come up with some ideas, right?
Right.
Okay, so you do your physical exam. What are some things that you look for on the physical exam that will kind of push you towards you versus my problem? My problem is pinched nerves.
Sure. So I think one of the main things we do is feel pulses. So you can there's
Sure.
points in the foot, in the groin area, behind the knee that you can actually palpate the pulse.
Gotcha.
So if you can feel a pulse, that's always a good sign. But sometimes there's reasons why you can't. Their blood vessels may be deeper than usual.
I have very deep veins, so
Okay.
I don't think I got a lot of cushion. So I got deep arteries.
So that can always be a problem. But there's some patients that have pretty normal circulation. I've been feeling pulses for years, and I still can't feel one of their pulses maybe. So you can't just rely on that.
Okay.
There's other softer signs, like some thickened toenails can sometimes mean that they're developing, they've got some arterial disease. They may have a loss of hair over their lower leg.
I was going to ask you that. Some skin changes, right?
Particularly in the foot and toes.
Gotcha.
Some people lose some hair on the lower leg, but it's preserved in their feet and toes. If you have good hair on your feet and toes, you've probably got pretty good circulation.
Okay.
We can pinch the toes and see how the color goes and comes back. The color comes back pretty rapidly. That generally means you've got fairly good blood flow at a smaller blood vessel level. Mm-hmm. So that you usually will say that the larger blood vessels must be good if the smaller blood vessels are good.
Are there any tests that you can do? So you've done your exam. You kind of think it's a blood vessel problem. And are there any tests that you can do?
There are some tests, and most of the tests that we can do in the office are pretty non-invasive. So we can do some simple things like put some blood pressure cuffs on the legs. We can measure the pressure and see the pressure using a handheld Doppler, which listens to the blood flow, and we can get some idea of how that waveform looks as to whether or not it's normal. We can measure the pressures and know generally your blood pressure in your arm is slightly lower than in your leg. So we look at that ratio, and if you're above 0.9, then you're generally in the normal. Once you get above 1.3, then it's abnormally high, but that may be because of calcification or diabetes.
I think this is a good time to start answering some of the questions that we're getting
So
from
I
the
want to
audience.
ask you one question though first.
What?
So one of the common questions that I'll get after they've been referred to me because it's a circulation problem and their legs hurt, and I'll say, hey, look, I think this is a problem with your back. How can it be a problem with my back, doctor? I don't have any back problems.
True.
So, I want you to say why it is your back, because it's their legs, it's not their back.
It's a very common thing we have to, that we answer all the time.
I'm sure it is.
And so we do the same thing. History, physical exam, important. Diagnostic tests will be a little different. We'll do an MRI, X-ray, CAT scan. And what we do then is we listen to the patient's problems, and we'll say, your problem is your calf or your foot because you have a pinched nerve in your back. And we go through the anatomy of where the nerve ends, which is where they're having the symptoms, and we follow that back to the spine, and then show them, yes, this nerve right here is pinched, and you're lucky you're not having back problems, but you're having something where that nerve goes to. And so it takes some education and knowledge, and we honestly will spend a long time so that they truly understand and answer your question. I don't have a back problem. Well, yes, you do.
Right.
It's just not affecting you. It's affecting you in a way that you're not thinking it can. And so it's really getting them to understand, like, our spinal system is really complex, and it can affect people different ways.
Sure.
So, first question. You're not off the hook.
All right.
Go ahead.
All right, we have a question coming in from Jennifer from Bernie. She says that when she likes to watch movies, she likes to curl up on the couch with her legs underneath her, but her legs always start to get tingly and fall asleep. Is this something she needs to be concerned about?
Okay, first, Jennifer, is this one movie, or are you binge watching on Netflix? That's a question we ask. I mean, I'm going through a series myself with my wife, and I can tell you, I'll start binge watching, and I'll sit there for hours. But in all seriousness, this is a problem that you may get. I get that sometimes. Is my legs go numb and tingling? I got symptoms from that. So what do you think?
Yeah, usually I think that's a positional problem, just from being in a certain position. You may get some compression. You could get some compression of the blood vessels, but I think it's like falling asleep on your arm, right? You're in this position. You've got some little temporary pressure on something. It's not really abnormal. You just need to shift positions.
So what happens if she gets up and says, I'm moving around, and really the question is, it doesn't get better, or it happens all the time. Is that something that she should be at least get evaluated for?
Well, I think, in particular, if it's not, an instance that you could say it's always when I do it this way, and if I'm not in that position, I'm better. But it's coming on at other times, or it seems to be getting more progressive, then yeah, I think, it's always worthwhile just to get an evaluation and
I agree.
Sure.
I agree. So Jennifer, again, don't binge watch. I'm sorry, I do it, but certainly look at your position, change your position. But if this problem is continuously affecting your life, or you're starting to see some of the other signs Dr. Martinez is saying, yeah, you know what? Reach out to him. He'll do an evaluation and kind of stratify your risk and see if there's any underlying problem to your numbness and tingling after watching Netflix. Next question.
Our second question comes from Thomas from Corpus Christi.
Hey, Thomas.
Thomas would like to know, are there things that I can eat that will help reduce the possibility of blood clots?
Wow. Wow. My doctor says there's things I shouldn't eat that can that can make me a healthier person. And so first of all, again, and also, yes, my doctor, I just had a physical, and he says, look, you got to kind of watch your carbohydrates, fat intake, high protein, low carb kind of idea that he proposed to me. And that was just for general health. So I imagine that the healthier we are, the healthier we eat, will affect not only maybe your nervous system and your vascular, but make just a healthier person who we are. What do you think?
Yeah, I don't know that there's really anything specific that you could eat to help you avoid that. I would say that, after the age of 50, everybody probably ought to be on an aspirin a day at least. That gives you a little protection. Probably not enough if you're really going to have a blood clot in the leg. But,
So what does aspirin do?
aspirin affects parts of the cells in the blood system, the platelets that are the kind of the initial clotting factors. So it can delay that clotting and minimize that to some degree. So that can prevent the start of a clot in some instances.
Okay.
It's not going to stop the clot if there's really a blood clot coming on, but it can help avoid it. But I think, like you said, a good healthy diet, regular exercise, that's probably the best way to prevent
Gotcha. Hey, Thomas, I'm going to take your question one step further, if I may. What about beets? And what about, and I'm really asking you a question about nitrous oxide, right?
Yeah.
Which you guys may have heard about nitrous oxide, about that. People take nitrous oxide supplements. They get foods with nitrous oxide. First of all, what is nitrous oxide?
Yeah, it's a chemical that helps to dilate the blood vessels, and there is some evidence to show that can help promote blood flow. The question really is, what about the person who's already got bad blood vessels? Does it really make a difference? And I don't think we really know the answer to that. Now, if you want to take those things, it's not really any harm in it. So if that makes you feel better and you feel like it's working for you, take it by all means.
Okay. I've heard, there are other things like nitrous oxides can help you with, and I've heard debates and pros and cons of nitrous oxide. So I think that the science isn't fully answered our questions yet.
No,
right?
I don't think so.
Yeah. So certainly, Thomas, there again, healthy diet, exercise, a baby aspirin a day. Those are some positive things, right?
Right.
All right. If you've been dormant for a while, how do you think? What's the advice you give to Lon?
Well, I think numbness, tingling, cramps, those are pretty non-specific symptoms in a lot of cases that can be caused from a lot of things. If it's a significant change, again, I would see your doctor, get evaluated, take a look. You can get some cramps from vascular disease, usually, and it can be at nighttime, more so into the foot than other parts of the leg.
Sure.
But not necessarily. But it can also be caused by other things, electrolyte imbalances, fluid balance.
Back to that diet stuff,
Yeah.
right?
So I think it's good to get those things addressed. Some simple lab tests, make sure your electrolytes are all in line, and then if if your physician doesn't feel like your circulation is appropriate, then we can always evaluate that and take a look and see how that lines up.
So one of the things, do you do telemed visits?
We do some telemedicine.
What do you think of telemed visits?
Well, I like telemedicine visits because a lot of what we can discern does not require actually seeing the patient.
Sure.
And if we need testing, we can get those testing closer to their home and then review those things, and that may be enough of the answer. What I don't like about it is it's feeling pulses can be really key for us.
Sure.
So I think it's a good first tool at least, because some of this may clearly not be something that's related to the blood vessels.
Sure.
And we can minimize the time on the patient's part of having to show up in the doctor's office.
Yeah, Juan from San Francisco.
Yeah.
Hey, Juan, so you do telemed visits. I incorporate telemedicine visits actually by suggestion of my wife. I started telemedicine before COVID. And so we find it as a useful tool that we can evaluate patients in an altered way, like we're doing today, utilizing secure ways that we can talk to you, evaluate your symptoms, and perform a cursory exam, look at tests, and we can come up with some ideas. Mm-hmm. And certainly, if warranted, Juan could call you, and you could do an evaluation.
I can only still practice in the state of Texas. So.
Oh, I didn't know that.
Yeah, so they can't. I don't think they can.
So Juan, you're going to have to come.
Treat them from
You're going to have to come to
California.
Texas. Sorry.
Yep.
So tonight we've had the opportunity to talk to what I think is probably our area expert here in San Antonio on vascular problems. Today we kind of delved into the difference between a pinched nerve presentation for a patient, or a blood vessel problem. You know, we've had the opportunity to talk to Dr. Martinez, ask him questions, and gain some knowledge from his base of, gosh, over 20-some years, right? Long time. And so I'd urge you all to reach out to your doctor, and you're always welcome to come to our practice, MD Spine Care, and Dr. Martinez is accepting new patients. If you have this problem of cramping, tingling, numbness in your legs, activity related, it's a topic that we struggle with between his specialty and my specialty. What is it, a blood vessel problem or is it a nerve problem? But I urge you, if you have these problems, you know, they can be a sign of something more serious. And I would tell you at this point, if you have those symptoms, don't ignore them. Come and be evaluated. We're accepting patients, and certainly we welcome to our family.